Good morning, everybody. My colleagues have discussed in detail about the neurogenic, non-neurogenic and myogenic causes. I'll just enumerate few masquerades which resembles a nerve palsy and cause double vision. The very few conditions are available and let me enumerate one by one. Brown syndrome, Duane's retraction syndrome, blowout fracture, ocular myasthenia, Wernicke's encephalopathy and ocular inflammations have been already dealt with. So Brown syndrome. What is Brown syndrome? This is a condition causing restrictive strabismus. There is inability to elevate the eye in adducted position, both actively and passively. In case of superior oblique palsy, there will be difficulty in depression in adducted position. But in case of Brown syndrome, there will be inability to elevate the eye in adducted position. And it's more common in females, and right eye will be involved more commonly, and 10% of the cases are bilateral, and it is sporadic in nature. And the mechanisms, it could be divided into congenital as well as acquired. Congenital Brown syndrome is due to short or inelastic superior oblique tendon which doesn't allow the elevation. Tendon or a tendon trochlea complex abnormality can also lead to congenital Brown syndrome. And acquired Brown syndrome can be due to iatrogenic causes due to surgeries like scleral buckling, glaucoma surgeries where Ahmed implants are placed, or sinus surgeries. And inflammatory causes also can cause acquired Brown syndrome like Sjogren's, SLE and Graves' disease. And infectious causes like sinusitis can also lead to acquired Brown syndrome, and trauma as well. And usually the patient will have hypotropia, and the patients can be classified as mild, moderate and severe Brown syndrome according to the hypotropia. In mild cases, it will be present only in the elevated and adducted gaze. In moderate cases, it will be presented in the adducted position. And in severe cases of Brown syndrome, hypotropia will be present in primary gaze itself. So to diagnose it, we have few criteria. Again, deficient elevation in the adducted position, and less elevation deficiency in the midline position, and minimal or no superior oblique overaction, V pattern or divergence in upgaze, and restricted force duction because there is a shortening of the tendon, and an audible or palpable click can be heard. And on ocular examination, usually these patients will have full vision, and an opposite side head tilt will be present. There won't be any facial asymmetry. This patient has got a left head tilt, and you can see here there is difficulty in elevation in the adducted position. And just to compare, I have put a fourth nerve palsy also. Here the patient will have difficulty in depression in the adducted position. And differential diagnosis, it could be a true inferior oblique palsy, and how to differentiate this would be by force reduction test. Force reduction test will be negative in case of true inferior oblique palsy, and a monoocular elevation deficit also can be one of the differential diagnosis, and congenital fibrosis syndrome, or a blowout fracture, or Graves' ophthalmopathy. The second condition would be Duane's retraction syndrome. We all very well know about this syndrome. Here the clinical features are complete or less often partial absence of abduction, and there will be retraction of the globe and narrowing of the palpebral fissure on adduction, and an upshoot or downshoot of the globe with adduction, and widening of the palpebral fissure with abduction, and a deficiency of convergence also will be present. So basically in type 1 Duane's, abduction will be restricted, and narrowing of the palpebral fissure and retraction of the globe will be present on adduction. And when there is abduction, when the patient tries to abduct the eye, there will be widening of the palpebral fissure. Here the epidemiology, this is also more common in females, and it's the most common type of congenital aberrant ocular innervation, and 70% of the cases will be isolated, 30% will be associated with syndromes, and this has a left eye predominance. This is a case, I've shown two bilateral Duane syndrome as well as bilateral sixth nerve palsy. Here you can see on attempted adduction, here the patient is having esotropia with abduction restriction. Here if you see, there is Adduction restriction, on attempted adduction there is upshoot, and here there is narrowing of the palpebral fissure. And here also you can see there is narrowing of the palpebral fissure on attempted adduction, and abduction is restricted. It's a case of bilateral Duane syndrome. This patient has got bilateral 6 nerve palsy. So how will you, here abduction is restricted and here also abduction is restricted. So how will you differentiate? The two key points are widening of the palpebral fissure on abduction and narrowing of the palpebral fissure on adduction, which will not be present in the case of 6 nerve palsy. So major types will be type 1, 2 and 3. In type 1, the eye will be esotropic in primary gaze, and abduction will be restricted with narrowing of the palpebral fissure on adduction. In type 2, there will be exotropia with adduction restriction and abduction will be normal. And type 3, either esotropia or exotropia might be present. So the pathophysiology, many theories are available. The neurogenic theory is the most commonly accepted one. A disturbance in the embryological development between weeks 4 to 8 results in an absent abducens nerve with anomalous innervations of the lateral rectus muscle by a branch of the oculomotor nerve. That is the most commonly accepted theory. And cause of globe retraction is simultaneous activation of the medial and lateral rectus muscles. So the clinical features, to repeat again: strabismus, limitation of abduction, induced ptosis on adduction, poor binocular vision, amblyopia and anisometropia, and compensatory head turn will be present to avoid diplopia. This is a patient with right Duane's. Here you can see esotropia in the primary case. And the third condition will be blowout fractures. And 58% of the patients will develop strabismus, and it will be self-resolving within 6 months. This term, blowout fracture, must be used for orbital floor fractures commonly, not involving the orbital rim. But we use the term for fractures involving the medial wall also. So orbital floor fractures will be the commonest one, that is due to blunt trauma causing rise in the intraorbital pressure with cracking of the weakest wall. And medial wall fracture also will be classified as blowout fracture because it is the thinnest and buttressed by the ethmoidal sinus. This can occur in conjunction with the floor fracture. Lateral wall fracture can also occur, but roof is very resilient for fractures. So how will you deal with these cases? A careful clinical evaluation, careful history taking, periorbital swelling and ecchymosis will be present because of the trauma. Facial asymmetry might be present, and anomalous head posture will be there to avoid diplopia. And exophthalmometry has to be done to measure the exophthalmos or inophthalmos, whatever. Infraorbital anesthesia will be present, and crepitus also might be present. Why there is strabismus? What is the mechanism? Entrapment of the muscle or the orbital septa or the soft tissue in the fracture will cause strabismus. And muscle injury causing hemorrhage and edema also might be a cause. And exact nerve injury also can occur. Radiographic evaluation is very, very important in case of suspected blowout fractures. CT scan with thin sliced direct axial coronal and other sections will be useful. A trapdoor sign will be present. And we have to look for the location of the fracture and effect of fracture on the orbital volume and the effect on soft tissues. Here there is a medial wall fracture with protrusion of the soft tissue. Here again you can see the orbital floor fracture. And this is again a blowout fracture with hypotropia and ptosis and with difficulty in elevation. Some cases might have hypertrophy also. Here you can see the orbital floor fracture. Here again the floor fracture, blowout fracture with the trapdoor sign. And ocular myasthenia is another condition, and this will resemble any nerve palsy. It can resemble third nerve palsy or a sixth nerve palsy depending upon the presentation. But few key points are available to diagnose it as ocular myasthenia: fatigability, diurnal variation, and Cogan's leg twitch sign, orbicularis oculi weakness. These are the key points to confirm it is a case of ocular myasthenia. As everyone knows, it's a chronic disease of autoimmune origin in the neuromuscular junction of the skeletal muscles, thus resulting in weakness of the voluntary muscles. Here again, Like any other nerve palsy, ptosis, diplopia will be present. The careful history taking. In history, the patient has to give a history of diurnal variation. The patient will be absolutely normal in the morning, and as the day progresses, the patient will have drooping of the eyelid, which will be absent in the case of third nerve palsy. In third nerve palsy, the ptosis will be permanent in the morning as well as in the evening. But in case of ocular myasthenia, the ptosis, the diurnal variation will differentiate it from a case of third nerve palsy. And extraocular muscle involvement, any muscle can be involved, and the pupil will be always paired. Pupil will be absolutely normal, briskly reacting in all the cases of ocular myasthenia. But in case of third nerve palsy, pupil might get involved. So again, this diurnal variation, fatigue test and ice pack test will differentiate and confirm ocular myasthenia. So this is a patient with ocular myasthenia with ptosis. After ice pack test, after keeping the ice pack on the ptotic eyelid for 2 minutes, the patient has improvement in ptosis. This is a case of ocular myasthenia. This is a case of third nerve palsy with ptosis and exotropia. The ice pack test was negative in this case. So this is a key point in differentiating myasthenia. So this is a video. This patient has got abduction restriction. Here you can see, adduction restriction, elevation restriction, minimally, and depression. It almost resembles third nerve palsy, but it was a case of ocular myasthenia by the history and all those which was explained earlier. And one more interesting condition is vernix encephalopathy. Here the patient will have ophthalmoplegia as well as ataxia and confusion. This will be due to vitamin B1 deficiency due to chronic alcoholism. So by the history we can differentiate. So the patient will be a chronic alcoholic. You have to ask for his sudden onset of ophthalmoplegia, a sudden onset of double vision, and if you ask the history, he will give history of chronic alcoholism. So associated with ataxia and confusion, so you can think of vernix encephalopathy, and MRI brain, if it done, will show any of the mammillary bodies. So an injection of thiamine will resolve the condition. And these inflammations are being dealt with by my colleague in detail. And these are the few conditions which masquerade a nerve palsy. Thank you.